So I will be talking about visual evoked potentials. So the electrical signals which are generated at the visual cortex in response to visual stimulation are occipital responses which correspond to the central visual field, and they help in assessing the intracranial visual pathways and their functional integrity, right from the retina to the optic nerves to the optic chiasma, optic radiation, and the occipital cortex. The peripheral retinal projections are within the calcarine fissure, while the central retinal projections are along the occipital lobe. The foveal projection is magnified at the cortex, where m is the linear extent of cortex in millimeter. At the fovea is around 5.6 millimeters per degree, and 10 degrees away from the fovea, it reduces to 1.5 millimeters per degree. So the indications for VEP will be optic neuritis, multiple sclerosis, optic atrophy, evaluation of hereditary optic neuropathies, toxic neuropathies, traumatic brain injury, compressive optic neuropathies, glaucoma, and amblyopia. Also, we need to do it in cases who have unexplained visual loss, malingering, pre-surgical evaluation, and measuring of visual acuity in non-responsive subjects. So the requirements here, we have the similar type of electrodes, active, reference, and ground, where the impedance should be less than 5 kilo ohm, and the impedance difference between the active and reference electrode should be less than 20%. The placement of the electrodes follows the 10-20 rule, in which the top of the head is divided from the nasion to the inion in different parts, and the ground electrode is placed over the top of the scalp. There's the reference electrode and there's the active electrode. This is how the machine output will show if there is the impedance of any of the electrode is nearing 5. So we need to reattach the electrode. The stimulus used for VEP can be flash, pattern, color, or motion. For flash VEP, the Gansfield stimulator is used, and in pattern VEP, the CRT monitor is used. Now, looking at pattern VEP is most commonly done for patients having good visual acuity in a light adapted state at 1 meter with correction in undilated conditions monoocularly. Here, the requirement is a checkerboard pattern. Here, the pattern is reversed. We have different check sizes of 60 minutes and 15 minutes. The luminance is constant, 40 to 60 candela per meter square, and the contrast is high. Flash VEP indications would be same, but here done in patients who have poor visual acuity, light adapted, and the room is dimly illuminated, done monoocularly. Here the field size is more than 20 degree, and we have to give at least 1 flash per second, that is 1 hertz frequency. Flash intensity is 1.5 to 3 candela per meter square, with a low background intensity of 15 to 30 candela per meter square. The pattern onset and offset VEP, here the pattern is flashed on and then off. So pattern will be done for investigation of optic neuropathies. Flash VEP to be done for patients having poorer optics, poor cooperation, poor vision, and where pattern reversal cannot be done. Onset and offset VEP will be done in cases of nystagmus, malingering, and amblyopia. Coming to pattern VEP, as I earlier said, this is the checkerboard stimuli where the pattern is reversed. Here we need to reduce artifacts like blinking of eye, the lesser the better. The number of tests done per test at least should be 64, and these tests are repeated twice. In infants or uncooperative patients, the numbers per test can be reduced. Now, checks which subtend an arc of 15 minutes are the best stimuli for testing foveal vision, and larger checks of 16 minutes are superior in evaluating parafoveal function. So, when we are using more than one check size, this increases the diagnostic yield. If the resulting VEP using the 60-minute check or the larger check is poorly formed, then we need to retest it using a larger check size or use a pattern onset stimulus. So this is how a waveform would look. Here we have few positive and negative waves in which P100 is important. Its latency normally is 90 to 110 milliseconds, and this can be standardized lab according to the lab. And its amplitude is important, which is more than 5 microvolts in normal cases. So this is how the output will look for both the eyes, and done twice for different check sizes. This is a normal waveform where you can see that the latency and amplitude in both the eyes is comparable. Coming to traumatic optic neuropathy, where the left eye was involved. Here, if you see, as compared to the right eye, there is a delayed implicit time and reduced amplitude as well. In cases of AION, again, if you see, the implicit time might be normal, but the amplitude is reduced and the waveform becomes a little wider. Similarly, in cases of papillitis, implicit time might be delayed and amplitude might be moderately reduced. This is a case of optic atrophy with no PL, disc was pale, and it is a flat VP, no signal was elicited. Now, VP can also be used for evaluation in cases of neurofibromatosis having optic nerve gliomas and their progression. So, over a period of time, it can be seen that if the glioma is increasing in size, there might be some increase in the latency in the optic in the VP. Similarly, in toxic neuropathies, it can be shown that the P100 shows slower peak times. Other cases, for example, meningeal tuberculosis, prolonged latency might be seen. Coming to pattern onset and offset, here the pattern is flashed on and then off for double the time of an equiluminant diffuse background. Here also different check sizes are there. Now this produces a more robust VP than does pattern reversal in the central 30 degrees. So this is the difference in pattern onset and offset. It is on and then there's a equiluminant background, and in pattern reversal the check colors are reversed. So pattern reversal normally exacerbates nystagmus and interferes with the ability of the eye to maintain foveal fixation. So pattern onset offset is good for detection of visual acuity in subjects with nystagmus, for monitoring amblyopia, and in cases of malingering. These are the waveforms. Here the C2 wave is important. Its normal latency is 100 to 120 millisecond. Now flash VP, as earlier told, it is done for uncooperative patients having media opacities to prognosticate the eyes with poor vision before planning surgery and to monitor the visual function of babies. Now VP is often prognostic in delayed maturation of the visual systems. Usually the infant with delayed maturation will have a normal flash VP, while permanently cortical blind infants may have abnormal VPs. So this is how the output will look. Here a little alteration of the wave peak and troughs can be done to get a proper waveform, which can be then calculated by the machine. In flash VP, the P2 wave is important. Its latency is 100 to 120 milliseconds, and the N2 P2 amplitude should be more than 10 microvolts. And this is how the output will look. Just a small note on sweep VP done in infants, suspected malingers, or disabled subjects. Here the visual acuity can be extrapolated from the VP and calculated in logmar units. Multifocal VP has come up recently. Here this is an objective assessment of visual field or objective perimetry. It can be done in cases with glaucoma and chiasmal misrouting like in albinism. Here there is a bracket with 4 active electrodes and a ground electrode, and the output comes very similar to the multifocal ERG. It can be in a sectoral form or it can be in a ring form. This is how a normal multifocal VP will look for both the eyes. In cases of optic neuritis, it can be seen that in one eye, the central 30 degrees was abnormal, and after 2 months on testing, there was significant recovery in the amplitude, but slower peak time persisted due to demyelination. Just a recap of the major waveforms that need to be seen in VP. Thank you for your patient hearing.